Everybody, thank you for coming to the panel discussion on the future of health work in Africa. What will it look like in 2040 to 20 years from now? And then what are the implications for health systems? I want to introduce myself first. My name is Dai. I'm a Chief Technical Officer at the International NGO based in North Carolina, United States. And I work with our organization work on the various health workforce development issues. And I'm so happy that they're able to moderate this conversation today. Then next is the panelists. I want to go through that, introducing them. As you can see on the screen, first person is that the Shushu. She is a senior advisor, political advocacy and partnerships and resource mobilization from Global Fund Switzerland. Welcome, Shushu. And the next person is a Janet Moriki. The Janet is a program lead for the USAID funded Human Resource for Health mechanism in Kenya. She's a dedicated leader in the health workforce development. The next is Brian. Brian Gita is a team lead of the Think IT technology application development organizations based in Uganda. And finally, the last panelist is Andrew Brown. He's a senior director of health workforce development from IntraHealth International, that's my colleague as well. So these are the panelists, and then we would love to start the panel discussion now. The first will going to be my presentation. I will share my screen. Great. And we would really welcome, I welcome that everybody uses the discussion forum and then also the questions and answer box. If you are participating, that would be great if you can put your name and then from where that you are coming from, and then so that we would know who are in this list, who are in this panel discussion. So as I said, that this session is that future of health work in Africa 2040. What will it look like, and then what are the implications on the health system? So welcome to the future, and then why do we want to talk about future? Today's discussion about the future is basically two motivations for the organizing this panel discussions. One is to introduce the concept of scenario planning, and then also its use in the global health, using the future of the health work as a part of the discussion. So this is really the introduction of the concept of the scenario planning, but then also a really critical part of the discussion is about how we are going to see that the future may unfold. And then also the deepening the discussion with panelists in key action that the global health community must do to navigate various drivers of changes that may shape that the future of health work in Africa. We're going to have I'm going to present first 3 scenarios of the future of health work based on the research we have done in a collaboration with a lot of the opinion leaders and the influencers and then the researchers. And then also, then we'll ask the panelists the first question of the talking about their work and then how their work is going to shape or contribute to the future of health work. The second question is thinking about those scenarios that I'm going to present, what health work or health workers will emerge in the future, and then how they're going to be critical to improving the healthcare in Africa. And then third question is, what do you think that the global health community and health systems start doing or stop doing so that we will have a better health? for the next 20 years. And then we will have some invitation of that the questions and answers among the panelists, but then we will also open the question and answer to the floor. So we would really welcome you to put the question in the question box. So when we started to think about this work of the coming up with scenarios for the future, we wanted to understand what may or what kind of factors will drive the shape of the future. As you can remember, like 20 years ago, that around the year 2000, the Global Fund was established and then started to have the first disbursement of fund. And then also Gavi was established around the same time 20 years ago. So 20 years in the global health community can have a lot of significant changes. But then also that the some of the things has stayed the same. So what we are looking at, or in this study of the coming up with the future scenarios, we looked at the political factors, the coalitions and alliances, and then also that the change of the regimes, and then all those factors, and then also international influences. We also definitely looked at the technological factors, economic factors, and then social demographic factors, and then finally that the current hot topic of environmental issues, and then we saw that how they may or may not interact to each other. Just to quickly give some of the examples of flavor of the things, in the technology space, there are a lot of the money flowing into Africa as a financing of the venture capital for the technologies. The driver for these changes is around the financial technology sectors. But then, as Brian's maybe talk about, there are a number of startups happening in Africa and then driving the change within for the technological innovations and then the scale up. Also, that some other example of the factors we looked at is the first growing cities going to face the climate risks in the future. And then some data suggests that the larger cities in Africa are much more vulnerable to the climate changes than the other type of the cities in the or comparable size of the cities in Europe or Americas or Asia. So these are some of the influence that we may have to think. And then also that finally, like we are facing with this coronavirus pandemic. And then when we started this research, we didn't know anything about this was coming, obviously. And then the future is really something that we cannot really predict. But then we can only anticipate that the major changes and drivers are going to be there. So what we are trying to do through this scenario is that we try to acknowledge acknowledging the wider uncertainty exists. So rather than we try to forecast that the future is going to be this way or one way, and then within the plus minus 10%, we are trying to see is that acknowledging this really wide range of the influences, and then come up with envisioning a multiple future scenarios. Most of them are really extreme in some cases, but then some of them are much more at the same time plausible or realistic, so that we would be able to prepare for the future in the wide range way. We can prepare ourselves now for the 20 years that are going to come. So that's the purpose of our work on the scenarios. And then I have also inserted a link to the report so that if you're interested, please, you can access to that report then and have the, you can download the report. So after all those discussions and the researches and workshops, we came up with 3 different scenarios of the future, how the future of the healthcare work look like in Africa. One future is we titled Cyberpunk Africa. The Cyberpunk Africa is basically technology calls the shots. And then there is a much more bigger technology boom, and then powerful non-state actors driving. And then lagging governance around the health technologies may create that the huge advancement in the some parts of the populations, but then there may be a populations that become a vulnerable to a like a data harvesters or power brokers, and then also a the unstable or not really a that the safe or helpful technologies in the future. So that may be a much more wider cyberpunk kind of like a situation in the healthcare may be happening. The second future that we envisioned was a further together, where that the universal health coverage is redefined. This is no more about just the healthcare coverage, but then more broadly looking at the well-being of the society. And then this is driven by some of the crisis like a pandemic, and then new generation of the leadership is emerging and drive the changes in across Africa towards the healthcare. And then there will be a much more new and innovative form of collaboration across countries and across populations, and then agencies and partnerships. The third model is the third scenario that we identified as a pattern is the muddling through. This is more like a business as usual. Universal health coverage on the newspapers and the article may be declared, but then there may be a lot of power play there that does, and then still a lot of inequity exists in the patch of the populations. It's a protection of the status quo of the healthcare workers or healthcare professionals. And then there are political inertia and gridlock to move us forward because of the healthcare is seen as a more of the political and then financing component than the actual well-being part. And then there are stagnation in the resources allocation to the health. So I just want to talk a little bit more about how those each scenarios have the potentially influence the type of the health work for the future. So under the cyberpunk Africa, who may be playing or who may be considered the health workers 20 years from now? They are no longer the traditional way of physicians and nurses and a midwife and community health workers. There may be a new cadre of the health worker like health data harvesters. So these are the type of the people who would be working and then collecting the informations and then also selling those informations and dealing with it. Many of you probably have used the Uber and then also like other ride share service. And then health work is also going to be like a gig work. So many people may be providing part-time support and then maybe not even the licensed or registered services based on the time available. And then even like across the boundaries. If you look for a mental care at the 2 a.m. in Uganda, you will get it from the somewhere in Africa for those kind of services. But then, how do you know that those people are actually licensed other than the claim that which you may see on the screens? Patients may be themselves aided by the technologies, especially like used by using the amplified capacity with the AI assisted tools. And then, now already that we have smartphone based diagnostic algorithms, and then that may become a widely available, and then people may start to rely on the different type of those algorithms as they see it, fit for their lifestyles. There are a lot of, like for the health workforce, that there will be a lot of frequent learning and the relearning of skills because technology changes very rapidly, and then the popularity also changes. Providing the high quality and then also concierge type of the service will become very important for high income patients, because high income patients want somebody else to worry about those technological choices and the diagnostic services. And that may not be anymore the physician's power, but then there will be a concierge kind of like a help desk kind of services may emerge as a type of the work. in terms of conditions, there will be a highly fluid health labor market with the gig economy kind of sorting of the workers happening, and a lower level of official accountability. But then the healthcare work is much more reliant on the patient reviews and reputations on the social media. And then more black box diagnostics and care technology will start to come in, and then who owns data is going to be questioned. So many companies may claim that your privacy matters to us, but then that's actually their profit. Another future that we have envisioned is the modeling through this case, as I already said, that this is status quo of the power dynamics. There will be a very strong protection of the existing tiers of licensed professionals with some formalization of the community health worker levels too. There will be a provisionally credentialed professionals that in order to meet the shortage of the workers. And then there will be a lot of specialty clinics and care providers. And then this becomes really a huge economic driver there. There will be a lot of NCD, non-communicable diseases work, but then fragmentation will continue because more specialty clinics and care providers there, they want to maintain their income, and then there's less motivation for integrated services under this condition. Similar care as today with more technology tools, and then more variability in care on the ground, even though the same diagnosis. So you may get the same diagnosis, but then if you go to a pharmacy, you get some kind of like a treatment, and then you go to another doctor with the more sophisticated tools, then you will get a different type of treatments. And then that kind of variability would be further increasing from now in the future. The conditions that we are working on will be a accelerated public-private bifurcations when inequity increases the inequity in quality that you can access to, but then you may not know what you're getting. And a more expectation piled on the frontline workers because many people will have the access to those informations in some different ways, then there will be a high expectations that you must be able to do this or you must not be able to do that kind of discussion will start to happen. And then care decision-making authority shift to the insurance schemes under this kind of environment. Finally, that the further together, and this is where the healthcare is more like seen as a broader well-being, and then people are worried about after the pandemic or other crisis that they have to unite together. Under these conditions, there will be a much more expanded set of health and well-being workers. It's not just anymore that the healthcare workers, but then the type of the support that we will provide will be more about the mental health, and then also a nutrition, and then other sort of like housing kind of work is going to be a very important in relation to the health work. Large number of enabling cadres to support expanded services has to be there. And then also really revisiting and then also celebrating and then giving the importance to the indigenous healing techniques and support will become really critical under these conditions. Not just those kind of medicines and then that the clinic setups, but then there are many other ways that we would be able to address that the healthcare. And then the lessons learned from the long history of the country or the regions becomes very critical here. More preventive and social work and then at the same time, more crisis management expertise going to be important. And then integrated multi-sectoral services. Healthcare tasks are shared and diffused, and then creating new professions. But then those are the work under the emergence of the new health leadership beyond the current conventional structure of the Ministry of Health and others. Technological systems and greater standardizations and controllable care. So there will be a much more unified care and an access to the services, But then there may be some cases that the state authority over what the people should be able to access and what can be reimbursed under this condition under this future may be stronger than now. There may be some cases like a borderless acceleration of the collaborations, especially around the pandemic or like epidemiological support, and then dissolution of the traditional boundaries of the profession may be happening. This is my last slide before going to the panelists, but basically these three scenarios has two major factors are in play. One factor is that the health work power structure, how much of this power structure of the current health workforce are going to be preserved, like how much that the doctors and nurses and the midwife and all those professional kind of want to maintain their power structures and then their authority over the healthcare systems, and then also that the international organizations and then others. Or are we going to see that those power structure much more diffused and then distributed, and then there may be a new entirely different type of the power structure emerge? So how much of these structural changes are going to come will influence our future? And then another factor is that how much of those benefits of the technologies are going to be distributed or controlled and managed. Is this something like that we will lose the grip on the control of the benefits of the technological advancement and then become really patchy advancements, and then some places are lagging behind? Or are we going to create a governance or mechanisms that we can harness those technologies to the greater goods? That will also changes our future in the great deal. So I'm going to stop sharing my slide, and then I want to go to the panelists to have the first question. So maybe I want to ask the panelists, my first question of, maybe you can introduce your work first, yourself and your work, and then how you are contributing to driving the future of the health work in Africa. I would like to ask first, Shushu to take the floor and then talk about it.
Thank you, Dai. Thank you for having me in this panel. I need to start the video. Yes, thank you. Okay, thank you so much. And good morning and good afternoon, wherever you are. So my name is Shushu Tekle-Heimanot. I work for the Global Fund. The Global Fund is one of the largest health financing institutions in the globe. And we work, a lot of our resources goes, around 72% of our resources is redirected to Africa. Working on the 3 diseases, but also the related health systems. So we give around 1 billion, focusing just solely around health systems. And our work, particularly around health workforce, though not directly, it is indirectly, because we try to help countries to invest ethically in health workforce and also in some of the related health systems. So around the health workforce, what we ensure is that, there's sustainability, that there are costed plans, that they are following national strategies. We are ensuring that investments are supported by robust data and evidence, and invest in equipping human resources, that they have competencies and the work environment, and that they are integrated to provide services that are people-centered, especially around focusing on community health workers. And then we also engage a lot with strategic partners to work. And so one of the work that I'm currently doing is partnering with the African Union is on health financing. And health financing, as you know, is the wide, comprehensive, encompassing to ensure that countries themselves are raising their own resources. It's called an initiative, the African Leadership Health Financing Project, where President Kagame is the lead. And we want to ensure that countries are able to have adequate resources for the health systems that they need, but they also to own and sustain all the program. So the Global Fund work is huge because we provide a lot of resources, we have a lot of leverage, and we do influence a lot of the processes in country together. And our main support is really to ensure that countries have a consolidated, resilient health systems that delivers for the people, and particularly at the community level. So what I see the future, and I hope we'll talk more about this, but in the future, what I hope is that African countries are able to manage and own their own and their health systems with their own financing. Of course, that it differs. There's going to be mixtures. In the short term, there is need for additional resources, but I think in the long term, the play is that we have seen some of the scenarios where we're going towards to. So I'll stop there and then we can talk about the scenarios.
Great, thanks. I would love to hear from Janet about your work and also how your work is contributing to the shaping the future.
Yes, thank you very much, Dai. Good morning, good afternoon, good evening, participants. My name is Dr. Janet Moriki. I'm the program lead for the USAID funded HRH Kenya mechanism, and also IntraHealth International country director here in Kenya. Yes, so I'm very excited to be sharing on our work this day. We're doing a lot in preparing the future for health work in Africa. One of our key areas is really expanding on the pool of health workers and also ensuring that they get the required competencies to execute on their work. We do this by having an innovative fund known as the Afialimu Fund. And this is different. It's not a scholarship, it's a loans product where students are able to access loans and take on a career into medicine. The other thing that we are doing here in Kenya is using the integrated human resource information system. This is anchored in government, and we are able to put in it all public sector health workers. It provides at a click of a button decisions for our leaders to make on whether to recruit, what are the gaps in terms of the deployment, where do we need more health workers, which cadre are people looking for. We have also added in this time of COVID a component of communication into the system. And this is known as M-Hero. It builds on work IntraHealth has done previously in Liberia and in Sierra Leone. So we have this, and we're providing SMS communication to our health workers, giving them tips on how to look after themselves, tips on what are the new government protocols and guidelines. And this is actually being well appreciated by our health workforce. We're also working to look at supporting preventive services. And here we're looking at enabling lay health workers who, task shifting has been with us, but these health workers are not recognized. So we have been working in the past with the Ministry of Health and Kenya's Public Service Commission to create a scheme of service for this community health personnel. And in addition to that, we are working with our medical training college here in Kenya to train these community health extension workers, or in Kenya, we also call them community health assistants, to put them on the ground to provide preventive services across HIV, reproductive maternal child health, non-communicable diseases, and even more recently on COVID. And in this environment of COVID, we have been proactive with funding from our donor USAID. We have taken up and embraced technology. We converted content from a curriculum onto on made 3 online courses available for our health workers. We have a course on critical care of COVID patients. We're also looking at human resource management of our health workforce in this time of COVID. And lastly, we're also looking at the community health assistance. What messages must they pass on to the volunteers and the community at large on matters COVID? So these are some of the courses work that we have done in preparation of our workers. We have even looked at our community. In Kenya, we have devolution, so we have management teams at the county level. How do you provide them with soft skills on leadership management and governance? We had a period where there was a lot of industrial unrest here in Kenya around 2016, 2017. This same training was extended to our union leaders, both at the national and the sub-national level, and ensuring that they have the soft skills to sit down at a dialogue table with the health leaders and kind of mitigate the extent of the industrial unrest. So we have been at the forefront of really supporting matters within our health workforce and ensuring that we are proactive in preparing this future workforce to deal with pandemics like COVID, HIV, and also any new developments in the field of reproductive maternal child health. Thank you.
Thanks, Janet. Just for all the panel, the participants, we are actually taking the polls on your platform, and then we would love to hear that which future that I have presented, Cyberpunk Africa, Modeling Through or Further Together, will come real in 10 years time, and then also in 20 years time. And then it would be great if you can also put your opinion there too. I want to go to Brian to talk about your work and then also how your work is going to shape the future in Africa.
Sure, thank you, Dave, for having us. Good morning, good afternoon, and good evening to the participants. Very happy to be here sharing about the future of healthcare. My name is Brian Jita, I'm team leader at Think IT. And at Think IT is a company that is aimed at delivering e-health solutions to the community. And our main objective is to see that we close the gaps between these communities and their rightful access to healthcare using technological tools. We have been doing this over the years through targeting a specific disease, malaria, and we have been the first solution that we are offering to the community is a diagnostic tool. And this is in a bid of delivering timely and effective diagnosis to the communities because we realized over time that the problem is not that there's no available medication, but one of the biggest problems is that people do not actually have quick and reliable diagnosis. So we're working with the community because we deploy human-centered designs and work with our health practitioners and work with ministries of health to really understand the problem so that we deliver solutions that are usable in the problem in the community. Because in most times, what happens is we develop all these programs or solutions without involving the communities that are going to use these solutions or without involving the other stakeholders into understanding what kind of policies are aligned, and we fail to make sure that these solutions are usable in these communities. So we have been doing a lot of community engagement and activation on diagnostics and understanding what the problem is and how our technologies can improve diagnostics. And one of the greatest insights was initially we were thinking these diagnostics will be at a household level, but we realized with these interactions that at a household level, it would rather cause more self-medication. And that's helped us iterate and then target delivering digital solutions for diagnostics at the health facility so that we offer a pathway into them receiving the right medication and avoid the high levels of self-medication. One of the other things we do is disease surveillance, using digital tools to do disease surveillance. And we have been able to deploy this in Uganda, and we have been able to track for more than a year back or survey malaria in over 50 hospitals, and also do a little bit of system strengthening with this by training the health practitioners on how to use these digital tools, but also training at a district level the health people on how to report the biostatisticians on how to report the data swiftly into the DHMIS systems. As also in a bid to deliver digital solutions during COVID outbreak, we as a company started to support government because prints and the ministries and some health facilities prints from waste that's from plastic, reusable PPEs, that is reusable face masks and reusable visors, which we have been able to distribute within the communities and the schools. So how our work supports the healthcare community is we see ourselves supporting at every level using a vertically integrated model to support straight from the communities, support them achieve or obtain the right healthcare they need in a timely manner, but also supporting the policy makers in getting the data so that they create data-driven interventions for these communities. Thank you very much.
Di, I'm afraid you're muted, but I think what you said was that you're introducing me.
Yeah, I was.
Thank you so much. Great to be on this panel with such a diverse and experienced range of panelists, and welcome to all the attendees. Encourage you to go across to the blog there to put your questions and details. I can see the number of people commenting, which is great. We want to sort of make this interactive. My role in IntraHealth within the Centre of Technical Excellence is to work to focus on health workforce. So IntraHealth is dedicated to health workers' improvement. We've been working in this space for some 40 years across a whole range of countries. And within the Centre of Technical Excellence, I have the privilege of trying to think through some of the technical approaches that our organisation can use and to get alongside our country teams to apply those to country contexts, mainly using USAID and CDC funding, and trying to, of course, improve the sustainability and quality of health workforce in those countries for the benefit of improved health services for people. We know the need is great. We keep hearing about these 18 million health workers needed for basic health service delivery around the world. And this problem is getting worse and not better. So looking at the future and planning is really important. For us at IntraHealth, our goal is to not only ensure we have sufficient quantities of the required healthcare workers, but to make sure that they're competent, they're resilient, and they're delivering these quality health services. And we like to think of present, ready, connected, and safe as 4 aspects of that to really prepare. Do we have the right numbers? Are they present in the right locations? Are they ready with the competencies and the equipment that's needed? And are they connected to their supervisors and peers? But really, and COVID's highlighted this, are health workers also safe? Do they have the PPE they need, but also do they have support, and are they free of harassment of any kind in their workplaces? This is what we focus on. And from a global level, one of the things we're trying to do is to look routinely at different trends that are happening globally and at a country level, and conduct experiments and approaches to help improve and reshape our thinking. So 3 points that are currently happening that I think are really important as we drive to influence the future. One is obviously COVID-19. And one of the big things it's done is really renewed and accelerated our interest in digital solutions for a range of health related issues: education, clinical guidance, data collection and analysis. And in the context of rapidly expanding internet, the potential to accelerate health gains in LMICs, I think, is very real. But those gains can only be realized if the health workers have the digital health competencies to engage in that, and that they are supported in a robust environment for that to happen. One of the exciting activities we're working on is with WHO to explore what these competencies are and how we can work with different levels of health workers to develop those digital health competencies for their roles and responsibilities. We all hear that funding flows are reducing, and this next aspect is very important. How do we improve domestic funding, but how do we improve efficiency of health workers? in the same way, looking after them. And one of the ways we're trying to look at this is increase the use of data at the country level to be able to make real-time decisions about planning for and mobilizing health workers and looking at performance in a way that's supportive to them. So for example, we've done some work recently with COVID around how to work out how many health workers are needed in hospitals in Kenya and Mali for various COVID-related severities of patients. We're also interested in sort of who's turning up to work, and some very integrated activities now in Uganda using simple biometrics to encourage health workers in their turning up to work and being able to look at that as part of performance. Another interesting area is looking at healthcare workers and how do you know as a patient that the healthcare worker is quality? And in Uganda, we have a situation where as a patient, you can text a certain number and with the details of your health provider, and the registration authority will tell you if that health provider is currently registered on the list. So coming back to this patient-centered care where the patients are perhaps a bit more in control. The third area is really realizing that there are changing patterns of competence that are required by health workers. We've spoken on this call about COVID, the increased use of healthcare workers, and the different competencies that healthcare workers are requiring for that. But the other interesting one is NCDs. And I heard Shushu mention this a little bit. And I was on a WHO call last week or so, where really NCDs now is more than 60% of the health burden. And lower middle income countries now have this double burden of disease. And so ensuring that there is not only the right equipment, but the right services are powered with the right competencies of healthcare workers to deal with this. Complex environment, the future is complex. And overall, what we're trying to do in IntraHealth is help to see how we can help build adaptive and resilient health systems to support health workers as they adjust to this changing environment. Thanks, Diane. Great to be part of this exciting discussion.
Great, thanks, Andrew, and then everybody. I think that what I have heard from all of you is there are a lot of innovations, and then there are also that the new technologies being introduced. And then with this, given the pandemic and then other the disease profile changes that Andrew just mentioned, that we are cusp of like the major change may started to happen. When I was looking at the poll, two polls that the participant contributed to, the first 10 years, like 70% of the people who are participating in this conversation saying like it would become like a muddling through. We're going to drag on for the next 10 years. But then the next panel of the next poll of for 20 years from now, then almost similar, or 63% is responding to the further together will start to emerge, and then the future will be different. And then I want to get the sense of from the panelists, like how do you believe that the future is going to look like? And then there are a lot of changes or potential changes you just presented and then talked about your work. Which one is going to really hugely influence, and then your influence is going to shape what kind of health work in the future. So maybe if I can go to a Shushu to talk a little bit about your sense that how the future unfolds, and then we'll go to the Brian and Janet and then Andrew. Thanks.
Okay, thank you, Di. So having listened with interest to your presentation and having read some of the documents, I believe it'll be a mixture of all the three scenarios, right? Because at the moment, countries are at different spectrums, different levels. So with that, I think there'll be, differentiated models, but even within countries itself, you could potentially have, different pieces, because sometimes even within countries, there isn't really policy coherence, right? There could be areas that are so far ahead, but maybe other areas not so far ahead, even within countries. So my view is that it'll be a mixture of all three scenarios. I believe technology will revolutionize, and already you see that in countries, and particularly with COVID-19. For example, in Rwanda currently, they're using a lot of AI, to address some of the health worker shortages and information. You see now in Ethiopia a lot of digital use, right, to ensure that data is collected, is used during in real time. You're using mobile data to empower community health workers. So I think technology will revolutionize the way, and even patients. You heard just how people, for example, in Nigeria, there's a center where you can actually call and get information about healthcare workers, health centers, are these quality centers, can you go to it, etc. So I think you're going to see that technology will revolutionize the structure and role of the health workforce, but also the health systems. However, it doesn't mean that there aren't going to be challenges. There are challenges around, and for me, some of the challenges are, okay, still there will be insufficient resources. Even as we go through and do this, there will be governance issues. For me, one of the biggest things is the governance and leadership is the ability to make decisions, the ability to plan long term. When you're talking about health workforce, you do need long-term planning, 10-year planning, but because of the constant change and governance issues, I think it could be different. Then the other thing is about regulations and standards. Who is regulating, whether it's the technology providers, whether it's the private sector health care providers, whether it is the ministry, those kinds of health. I think there would be huge improvements in some countries, and in some countries not. So for me, I think in 2040, we will have, I think reasonably more than half of the countries will have reasonably decent healthcare, particularly I think very strong primary healthcare that's focused on community health work, community. Now, as you know, even in the first world, the COVID has taught us this, that if you don't have forward-looking planning, and you can see that even in the country right now where I am in Geneva, countries were not able to deal with, and this shows that there was no forward planning to address emergencies, right? And I think this is where looking at global health, global public goods is going to be really important, but to be able to work together. So I do believe, I think in 2040, I will be around early 70s. I would hope that we do advance to getting some of the top-notch services. I'm originally from Ethiopia, and if I wanted to live there, that's the kind of things that I would be looking for, because somebody who's 70 looks for good healthcare, because that becomes really important in that age, and that when you're getting that age. So I would hope that a mix, some really good primary healthcare, but some also parts of really specific specialized healthcare. And I would hope that African countries would be able, and Africans would be able to receive that kind of healthcare within their own countries, rather than going abroad and say, all those resources that are coupled with going outside, etc. So that's what I would hope.
Okay, great, thanks. What do you think, Brian? How do you react to that? And then how do you see the future going to look like?
I think I agree to what Shushi is saying. There will be an integration of this for a solid future, but I would lean more so to the cyberpunk side of the future. Why I say that, if you look at 20 years back, at the early 2000s, the penetration of these enablers, which are the phones and the connectivity, was close to 1%. 20 years after, we are at around 45-46% of the penetration of these digital tools. That's phones within Africa, the penetration of phones within Africa, and the connectivity. So, and these conditions are making it favorable for the technology to thrive within different sectors. So I think that kind of change is also going to happen, and it's going to happen faster. Probably in the next 10 years, will be closer to the 80% mark. That way, we would have enabled the communities with enough technological experiences or tools to make sure that healthcare can be delivered. So I see healthcare facilities adopting technological solutions that can automate processes like diagnostics, treatments, building all these genome databases, and also offering better disease surveillance. And we've also maybe be able to offer rapid responses through kind of quick and effective dispatches of these health emergency services like ambulances. And I think a lot has to be done to get there, but I think we're on the path of getting there. And we have seen a trend where most of the people that are delivering healthcare services into communities are jumping on to technology as an enabler to help them reach masses fast. And it was evident during this COVID outbreak. Most of the ministries were able to put helplines, were able to, the World Health Organization was able to set up a WhatsApp channel where you could automate or speak to a bot or a robot that would give you quick responses on what to do, on where to find help. So I think this will resonate and drive down to a country level and see that technology is being adopted. A lot still has to be done in building capacity from the practitioners themselves, but also building capacity of the audiences to make sure that they're ready for this shift. Because from my experience, it's not easy for people to change the way they've been doing things. People are accustomed to the different ways, even if they are tiresome, that they've been getting healthcare services. So technology is an enabler, but we have to really do a huge sensitization on how technology can be used and not cause a lot of harm, because it's a double-edged sword, really. As it delivers these good services, a lot of information can be used against you as an end consumer. But I see the future being the cyberpunk.
Great. No, thanks. And then I think that the two themes like I'm hearing, one is the technological advancement may outpace our governance advancement, or like a people side of the advancement. And then that could create a mixture of cyberpunk driven, but then there will be some element of the further togetherness, and then collaborations may start to emerge. The one thing that I'm hearing also at the same time, though, is this in Africa, how the government reacted after the COVID pandemic started to happen. They actually did demonstrate some positive potential that they will be able to harness this technology for the greater goods, and then hopefully that would become a sort of like the good experience that the government and health system has had, and then can do more. Maybe that the future directions that we may be able to see. What do you think, Janet? We'd love to hear from your perspective and experience from Kenya. That how do you see the future is going to unfold?
Yes, thank you very much, Dai, and my fellow panelists. I want to agree with Shushu that we are going to have a mix of the two. The ones I see really standing out for me is the cyberpunk and also further together. Why I say this is, I think here in Kenya, and in Africa, we were leading in a number of fronts. We were the first ones to have mobile money, the M-Pesa. So M-Pesa hit the ground running because of that mobile phone penetration, and you could use it on a simple phone. But the governance structures came later. And recently, even as we were, just pre-COVID, we were looking at the Data Protection Act here in Kenya. And COVID comes, and we, as IntraHealth, were working on communicating with the health workers through this platform I mentioned, M-Hero, which is a two-way communication. So everybody is excited about utilizing the system, but the Data Protection Act actually acts as a hindrance. Nobody has really unpacked it sufficiently to guide our regulators on what information they can give us or telephone contacts for our health workers. But eventually, with good buy-in, we have been able to overcome some of these challenges. And to me, the most important thing to get into future together is actually for organizations ourselves to do pilots, startup companies also to do the pilots, should demonstrate to government the value of application of technology. How do you harness it positively to bring about impact? And this is what we're seeing with our two-way communication to the health workers. We've had scenarios whereby medical equipment has been provided for and distributed to our health facilities. But I think that was cyberpunk to me, because this MRIs, renal diagnostic equipment, catheterization for heart condition got onto the ground, but unfortunately the health workers were not aware of how to use this equipment. So I think when you want to harness technology, you need to plan appropriately, make sure the workers have the right skills and competencies to operate any new medical equipment in good time before you actually go out there and procure. We have seen, and that was really led by the private sector, because I mean, this was a state-of-the-art equipment from the developed countries. So really being able to bring those two sides together so that one does not run ahead of the other is important for purposes of bringing about efficiency. Shushu mentioned about specialized skills. We do need this, and specialization does not have an overnight. I mean, for anybody to get any new skill, it can take a year or 2 years to be trained as a specialized doctor or nurse. Therefore, you have to be forward planning. And right now in Kenya, we are looking at UHC, but at the same time, we also want to ensure that we're getting specialized services there to the community. And this means that you have to plan for both ends of the spectrum. You want to ensure that there's that universal access, and the health worker is available to the community level, at the lowest level of the dispensary. But at the same time, you also want to ensure that specialized services are not just at the big hospitals. You need to bring them down to the sub-county level and equip those facilities, ensure the health workers are able to have the requisite skills to provide those services. So I think this will call for planning, and part of this is through systems as having a one national human resources for health database being availed, being utilized, let it be used by our data scientists to generate reports, analytics, show what the gaps look like against the norms and standards, and how do we go about then making, ensuring that the production of these health workers, both at the generalized level and at the specialized level, are actually being provided and placed in the right facilities to provide the services. COVID has been interesting. As we began here in Kenya, I think everybody locked down, we stayed at home. The private sector, NGO sector woke up, but government took a while to embrace virtual meetings like we're having today, even this conference that we're having. So I think, but they have changed. We have seen national conferences being held on a virtual platform here in Kenya. So I think if we journey in this technology or innovation space together, we can do quite a bit. And telemedicine blended with still physical visits to the health centers is going to be our way of life. So how do we put in place the necessary infrastructure, allow our health workers to experience e-learning, what it means to actually do a virtual consultation, what soft skills do you need? Because this is not we are not reading each other's body language always when we are virtual, but how can we have the soft skills even translated online in this space of telemedicine? The call centers, I think somebody mentioned, how do we expand and utilize them more to reach down to our community for preventive services rather than curative? And how do we also prepare this community health volunteers in service provision during this environment where they have to apply virtual services in view of social distancing, but still be close enough to their community. I then think lastly for me is just looking at research and even looking at our graduates once they leave the medical training institutions. How do we ensure that they are fit for the labor market? And I think this is a question that is about preparing that future workforce in 2040. Are they relevant? I think is a key question. Will they provide me the specialized services I need if even old age health is my number one priority? So post-graduation surveys to match the labor workforce are going to be critical. So I think there's a lot we can do. The two spheres that may stand out for me in 2040 would be Future Together and also the cyberpunk. But private sector, we can do more and collaborate with our government counterparts and prepare regulations in good time and even ask for them. I think instead of running amok, let's call to be regulated so that we harness the positive aspects
Thanks.
of technology. Thank you.
Thank you. So Andrew, what I'm started to hearing as a theme is that there may be a mixture of the futures here, and then also like a critical importance of that. Also, question is there like greater expansion of that the private sectors came up from the Janet's conversations, and also there was a question from the participants. And then how the labor workforce is going to look like and the government's ability to plan. What do you think that how this is going to turn out from the labor kind of like health labor side of the future?
Yeah, sure. And it's quite exciting. I mean, if we go straight to that future together, I think there is more specialized career prospects so that you've got a situation where you can have some greater career paths in that environment. I think that for that future together, this intersection in the private sector that Janet's talking about is going to be crucial. As part of that, and to manage that well, it's managing the quality of both private sector health service provision, as well as the quality of the health workers working in that context. So not only the regulations and the standards, but how's the government equipped to be able to enforce that to protect the public? I think it's going to be very, very important. And I think about also the competencies needed. So, but the further together our health leaders are going to and managers need to advocacy, negotiation, adaptive leadership qualities, which I think are going to be very important. For the muddling through, again, if we're going to do better in that environment, the workers need those particular competencies. And we're trying to look to this more data-driven, improved system. But one of the interesting things with cyberpunk is that there's going to be more opportunities for a larger range of people in the health workforce space, but they will be more perhaps specialized into smaller areas because of the support they can have from technology. So digital competencies are going to be important. But one of the interesting areas we haven't spoken about with technology is that the patients also become their own health worker. Increased health literacy and the ability to do self-care quite prominent. So one of the skills health workers are going to need is to be able to fight that fake news. How do we equip our healthcare workers to be able to have those proper health messages heard over the messages around them? So I think it's going to be varied work, competencies for change from the mid and upper level managers, and particularly varied competencies depending on those contexts. Thanks, Di. We can't hear you again, just to let you know you're on mute.
My system mutes myself automatically. I'm sorry about that. I want to go back to all the panelists, and then maybe also that they each can ask questions too. But what I really heard as a repeated theme here is there could be a mixture of the different scenario becoming truth. And then there will be an element of the cyberpunk there. And then there will be an element of that the father together and the people collaborating. And then there are some sort of like people still holding on to power for the next 20 years. But then at the same time, like within the 6-8 months, many of the African government have demonstrated that, changing all those government technology within 6 to 8 months is actually quite a great achievement. We always talked about the immunization access and then others takes years, but then now that all those telemedicines and then even this remote meetings becoming a norm within 6 months of this cultural shift is amazing. You may not feel that quick, but then I think it's that this month and then changes happened was really amazing for me. So in that kind of environment, and then if that there are patches of the further togetherness and then also cyberpunk is happening, there may be some risk that the inequity of the new way of the inequity may become really more apparent, right? How do we avoid that sort of a emergence of the new shape of the inequity in Africa, and then making sure that everybody will have the access to the better healthcare as Shushu demanded. And then what is that? How are we going to, what do we have to start doing now? And then what do we have to stop doing now for the better future for us? I want to start from Brian and go to Andrew and Shushu and Janet. Brian, what do you think that we should start doing?
Thanks, Dai. I think we should, 2 points on that. I think one, more training or more capacity building has to be done, like Andrew was saying, so that we can be able to filter out what's the right information that we are sending out to the public. So a lot of sensitization is supposed to be done, and also a lot of labeling of these channels. What is the right channel that people should be listening to? What process in terms of policy should people be going through to ensure that they are going into these better channels to deliver all this healthcare? So I think that the policies should be adjusted to cater for even the small players, not only the big players, so that they can be engulfed in these new processes of sharing the right information to the communities, so that we can sieve out the wrong information. Because when you empower people with these technological tools, you need to really make sure that they're not doing, like I said earlier, more self-medication and driving change on the wrong information. I also think a lot of research should be done, and so that we make all the decisions data-driven. Because when you have this research done and you have databases built up, you will make all decisions on treatments, decisions on intervention, be data-driven. That way you can be able to see a quicker change and a greater growth of these tools in the communities. Thanks, Dan.
Thanks, Brian. Building on that, I think we can't predict the future, Dai, but we can prepare for it. So I think about this question, I'm reminded that the healthcare worker is at the front line of healthcare work, and that's the focus. But this need for soft skills by health workers, leaders, and managers being so important to embrace the future. And particularly thinking about encouraging governments to do investments to create adaptive and resilient health systems. And I think about what's our role at IntraHealth in being able to work alongside governments for that purpose. So how do we listen to those government priorities, help them to bring domestic funding forward, but then focus on what they need in terms of the advocacy, change management competencies to achieve change. The other aspect is, I think we need to think about the health labour market and the different institutions that are part of that and need to be part of that future. So we talk about the Ministry of Health, but we also need to think about universities, professional councils, health professional associations, the private health industry, and how can we come alongside them and help equip them with the soft skills and the thinking. They've got all the ideas and they know their context. But I see our role at IntraHealth is helping to strengthen those institutions so that they can work together to embrace that future, to make that make those decisions and navigate the way forward. So there's some building off Brian. Thanks, Di.
Yeah, a little bit, but then additional question is somebody also from the panelists also asked how the Mary Adam asked that how do we go beyond the compliance though, and then how do we go to place where the actual quality of care are not just about the meeting the requirements or being compliant?
Fantastic question, and quality of care is coming up more and more. And I think one of the areas is you need to have that regulatory framework, absolutely. You need to be able to have the equipping those government institutions to be able to build on that framework. But then working from the healthcare providers in and out is to be able to help them instill this sort of sense of ethics and quality. And I think that engagement between public sector and private sector in terms of healthcare delivery, it's not a shame to make money out of healthcare, but we want to encourage the private sector to do that in a way that's ethical, that is transparent, and that meets the needs of the people. So I think there's an element of that extra dialogue and engagement. Don't see private sector as being the opposition, but part of the problem and working together to a common future.
Thanks. Janet, what do you think that how do we avoid that sort of like a presence of what do we have to start doing now, and what do we have to stop doing now so that we can have a brighter, better future?
Yes, thank you, Dan, and my fellow panelists. I think for us, when I look at what could we do to strengthen this, critically, I think we need to build the capacity in government, make them understand this new innovation, new research, new technology. If we don't build their capacity, then we will encourage the cyberpunk, where we always leaving them behind, and of course, as we said, lagging in governance. But if we journey together by building their capacity, that's important. So buy-in and the capacity are going to be big for us as we're moving forward. I think Brian already brought out the part about policy. Policy needs not to be just driven by government. We want to have the private sector with us. We want to walk with them into this future because they're more flexible in bringing this innovation or new way of thinking. But I think at the same time, it will be onus on them to also ask to be governed. We have seen scenarios where medical education has been run by the private sector in some instances. And it's really disappointing to see medical students who may take certain courses and then not be able to actually work because either later on it's a matter of was the institution they were working with or trained accredited, was the curriculum accredited. So we do not want these professionals who spend 2-3 years studying and then are not able to actually provide those services. So I think it's the call for governance will be critical in the production and even in the provision of services, not to be quacks out there, but really bring yourself at the forefront, saying, I provide quality services, come and look at my hospital, make sure that I'm doing the right thing. I think that is also going to be important. Private sector should call on this. I think in response to the WHO, for countries within the African region for health repository, this would anchor a lot in terms of knowing the workers. It will also tell us be interoperable with the district health information system, saying these are the facilities, this is where we will send our health workers, this is the commodities that we need out there. These are the kind of leaders in management who we need to also produce to manage this system. And this is the data from the statistics, whether commodity, whether health workforce, that will help them make the appropriate decisions. So all this needs to be driven by data at the end of the day. So we must aspire for this and even encourage this cadre, M&E, monitoring and evaluation, health information, health scientists, data scientists, they are lacking. So we need to encourage, to reiterate Andrew's point, it's a party of journey to self-reliance. It's ensuring that we are able to get sustainability measures in place through domestic resource mobilization.
Thanks, Janet. I want to go to Shushu and I want to close and then thank everybody for the participations. But Shushu, I would love to hear from your final thoughts.
Thank you. Thank you, from very interesting thoughts from the panelists. You die. So just to be in the interest of time and also to be quick, I think the global health community is actually in a very unique time to be able to help at country level to really bring all the efforts together, right? So like, you know, IntraHealth, Global Fund, Gavi, whatever, we pour in a lot of resources. But I also think we don't speak as one voice in a coordinated manner, nor do we pool the resources together to really help the countries to maximize on that. Because I think the Global Fund has been putting money for the last 20 years, talking about his resilient health systems. And I've been working at country level and I see still, you know, lots of turf issues, lots of, even amongst ourselves. So I think the discipline also has to start with the global health community who is supporting the countries. Now on the country level, I think governance, leadership, and using evidence-based decision-making is going to be critical, and regulation. If we do not have the regulatory frameworks, the inspection, the norms and standards, the quality assurance mechanisms, I mean, you can have all these people, you can have all the technology, but you do need some sort of governance. And I think that's going to be really critical, that we need to get countries to help them. Then, you know, on governance and leadership, even within ministries, everything is centralized. You know, if you want to have decision made, for example, on resource allocation or resource distribution, right? It can't be centralized. I think we have to really work with countries to be able to empower people at the lower levels to make fast, quick decisions based on evidence and policies that are available, because I think that's important. And then it's, you know, it's decisive leadership, right? And I think this is what African countries have demonstrated. I think nature of what there's a saying that says mother necessity is important. So they're able, and where there's a will, there's a way to do it.
We have to close the session, but thank you very much. And then I think that they came again and again, this governance and the leadership, and then also preparing for the future. Otherwise, we're going to have the new version of the inequity maybe expanding, and then how we're going to harness seems to be there. And thank you very much for all the participations, and then appreciate. And then thank you very much for participating in the polls. And then thank you all the panelists for the really live discussions, and I appreciate your part. Thanks.
Thank you. Thank you, everybody.
Thank you, everyone. Bye.